I'm going to talk about some strategies that we're using in California to try to identify where the populations and providers are where we should focus increased TB prevention efforts. And I'm going to tell you all about these various definitions that I'm using throughout the talk, because high risk and TB prevention have different meanings for different folks, but I will get there. So the goal, of course, is to use data available to us at the state and in the form of public databases, in this case specifically administrative data sets, to figure out where should we prioritize our efforts. I'm going to tell you why we're going to need to focus down, because there's a very large population of latently infected individuals in the state of California. And we really would like to start with those that are at the truly highest risk of TB disease in our new efforts. So let me tell you a little bit about the context of the populations in California and our TB epidemiology. We have about 39 million residents. 10 million of them were born in other places outside the United States. And that the foreign-born comprise about 27% of the total population in California, and about a quarter of the foreign-born population in the United States. We also estimate that there's about 2.5 million undocumented persons, and this is a group of folks that we know are highly vulnerable because they are less likely to access care and to be available for TB prevention services. In California, we report 1/4 of the TB cases across the nation. So we're a pretty high incidence state in our low incidence country. And you've seen these trend graphs before for New York City. California's trend graphs look very similar. We have a different magnitude because we're a state and not a city. But at the peak of the TB epidemic, we had a case rate of about 17.4 per 100,000, which has declined to about 5.6 in the year 2014. I do want to point out, though, the area of the curve, as you see, there was a great decline from the peak, but through the years, and definitely recently, we no longer see a decline. In fact, I would say that we are, and our surveillance folks would agree, that we are at steady state. We really have the same number of TB cases from year to year, probably starting since 2011. We have about 2,100, a little over 2,100 TB patients per year reported. So this slide I borrowed from Dr. Pettenberry, our Chief of Surveillance and Epidemiology, and I think it's a really nice graphical representation of the impact of TB on our California residents. Each little person in this graph represents a TB case in the year 2014. And Penn estimated that what this really means is that TB is diagnosed in California every 4 hours. And you can see also that 77% of our TB patients are in the foreign-born. The countries, the main countries where our foreign-born TB patients originate are the following 5. So Mexico and Philippines are places that together 50% of our foreign-born TB cases were born. And then Vietnam, China, and India, their next highest countries of origin, with the remainder a mixture of many other countries. So how do TB cases occur in California? This is an important question because it helps us decide, Jean talked this morning at the earlier session about recent transmission being another way we can prevent TB. We need to intervene there to prevent TB. But if we look in California at the relative contribution of these 3 different mechanisms to how TB cases occur in California, we see that using CDC's plausible source case method that was recently published by Anne-Marie France and her colleagues at the CDC, their estimate for recent transmission in California is 13%. Now, when we look at the data, when we talk about importation of TB cases, what we really mean is that if looking over the 5-year time frame of 2010 through 2014, 835 of the 11,000 cases reported in that time frame were within foreign-born persons who arrived in the U.S. and their TB diagnosis was within 1 year of arrival. And so again, this is just an estimate. One can argue this, but clearly it's a much smaller number and percentage than the 79.5% of our TB cases that we estimate to be from reactivation of remote infection because they are not attributable to the other two mechanisms. So for the rest of my talk, what I mean by TB prevention is looking at patients who are at high risk of both infection and disease, and the goal is to identify them, screen them, test them, and treat them for latent TB infection. I will use the terms TB infection and latent TB infection interchangeably. So the questions to try to guide this presentation I chose were the following. Number one, what is the magnitude of TB infection in any given jurisdiction? And I'll start with California as a state. Two, what is the public health department's contribution to TB prevention? So what is going on currently in the state of California to address TB prevention through screening and treatment of LTBI? How many high-risk patients are tested and treated there? And are there missed opportunities? What are they? And can we address them? So finally, what is the contribution of private providers to TB prevention? So we can look at, the Affordable Care Act and the fact that a lot more foreign-born folks are becoming insured. Again, unfortunately missing the undocumented in this case, but we do find that there are more foreign-born persons who have insurance under ACA, and hopefully we can access them through partnerships with private providers who can extend the capacity of our ability to do TB prevention. And so again, we need to find out, though, where are the high-risk persons seeking care outside the health department, so which providers should we be looking at? And finally, is TB prevention optimized in various settings outside the health department? So to estimate the magnitude of LTBI, I took this slide from Penn and Berry, who basically applied the Haynes LTBI prevalence estimates from the recent study published by Rocky Miramontes and his CDC colleagues. And he applied the various prevalences by nativity and race ethnicity across the estimated population of California using, to be honest with you, I don't remember, it was current population survey or American Community Survey. There's different pros and cons to using those, but they're both census data products that are useful for identifying denominators and understanding our populations underlying our TB cases. Penn felt strongly that it's the IGRA positive tests that reflect true LTBI prevalence for the foreign-born, whereas it's TST positive results that reflect prevalence of LTBI in the US-born. And he'll be talking tomorrow, maybe you can ask him exactly what his reasoning is there, but we do know there's some differences in performance in the different groups. So by using this approach, we estimated, and this is a very rough estimate because we also want to look at age structure of our population, which will impact these final numbers. We're working with our UCSF modeling group to actually model, maybe give us a much more robust estimate. But using this very rough approach that I just outlined, we have 2.2 million persons who are infected with TB in the state of California. 0.6 million of them are US-born, 1.6 million are foreign-born. Okay, so how do we even begin to think about, doing prevention work here? So let's go back to those questions. What is the health department currently doing? So in the state of California, we have 61 local health jurisdictions. About 30 to 40 of them serve about 80% of our total TB cases. These health departments are responsible for screening, so doing case finding and TB prevention work among recently arrived adults who have abnormal chest radiographs from overseas screening. We call these the B notifications. Also among B notifications are the B2s. These are the children that are screened overseas with either a TST or an IGRA. And they also do the contact investigation. So any index TB case, they will do a contact investigation if they're infectious. The local health departments also do a lot of other TB prevention work in other types of populations, in substance users. However, we at the state don't collect those data. So I'm only going to focus on the three groups. So let's look at how much TB, how much testing is going on for latent TB infection among the recent arrivers. I wanted to orient you to this graph because what we have in blue is the total number of arrivers who had abnormal chest x-rays in the state of California in 2014, so about 3,500. The new arrivers that were children that were found to have LTBI on testing overseas were about 2,000. And those, the number that were actually evaluated, or the proportion that were evaluated, were 62% of the adults with the abnormal chest x-ray and 45% of the children. So there's a drop-off here in the potential for assessing all potential patients that are at increased risk of having progressing to TB disease. Then, if we look at all those that were fully evaluated to the point of determining do they have active disease, do they have TB infection, or do they have none of those, this group was infected, so a little about 1,800 folks. Only 33% of that 1,800 folks, of the 1,800 were started on treatment. Okay, we're getting these data, Phil Lowenthal generated these data from our B notification data set. So the question is, can we improve our evaluation where we see the drop-off, and then of course our treatment start, and we're not actually gathering robust data on treatment completion in this system. Okay, so we have missing data, we have questions about what more can be done, okay? So this is one of the pieces of the puzzle to help us say, maybe should we put extra effort here? Next group of folks are our contacts, and in California, 2013 is the nearest year for which we have our data. About 17,000 contacts were elicited. We don't know if that's truly 100% of all the potentially exposed persons in contact investigations, but if we assume that, 87% of that group were fully evaluated, 22% were found to be infected, 64% of those who were found to be infected started treatment, and 62% of those that started treatment actually completed treatment. What that means is that only 40% of infected contacts completed treatment all the way through. So this is a demonstration, I don't think this is news for any of you at TB programs, that there are potentially missed opportunities. You know, why are these folks not starting treatment? There may be actually some valid reasons, but for 60% to not complete treatment of infected persons, that's probably not completely explainable by, you know, valid reasons. And so these are things, yes, valid in the sense of the resource environment, but can we do better is the question. Okay, so in the state of California, we have estimated our huge underestimate of only these two types of populations, the B notes, adults and children, and contacts. There were 23,000 high-risk persons that were screened in our TB clinics, and we may have an opportunity. We have data that tells us now that only 33% of new arrivers with LTBI started treatment, and 40% of the recent contacts with LTBI completed treatment. So moving on to the next question is, what is the contribution of private providers to TB prevention? So here is where I really get into the exploratory phase. This is really just the beginning of us trying to figure out how do we do this. There is no recipe, but I'd love to hear from you if you all are doing different things, what kinds of things you're thinking about, what types of methods you may be exploring. And I think that we can, you know, work together as a nation potentially think about this if we think it's a worthwhile process. So where are the high-risk persons seeking care outside the health department? First, let me talk a little bit about what I mean by high risk for this set of people. So this diagram just shows you the Venn diagram, the intersection of those who have TB infection risk and those that have TB progression risk. And really, the folks we want to start off with are going to be those who have the intersections, okay? So a TB infection risk would be folks who are born in countries of medium and high TB incidence. And a progression risk could be any one of the following. So here is just a table that shows some of the, again, the known risk factors for TB progression. And the high relative risks from 2 to up to 12 relative risk for these different conditions. So in a patient that's infected, these persons are at higher risk to develop active disease than someone without these factors. So how can we answer this question? So in California, the providers, our main different categories of providers are we have this large HMO serving Northern California and Southern California. We have community clinics called federally qualified health centers, and these are organizations, clinics that get grants from the federal government through HRSA. And they, one of their goals, their mission is to serve underserved populations. So they mainly serve folks on Medicaid or uninsured persons. And then, of course, there's the individual private practices. There's a lot of university-based practices in the state of California, as well as these individual practices. So how do we even begin to think about where to start in terms of providers and populations? So there's potentially two streams. One is start with the TB patients. Okay, and so in the left-hand side of the panel, the question is, who provides primary care to that TB patient? Who provided primary care to that patient prior to their being diagnosed with TB? Because that suggests a potential opportunity for the primary provider to have determine whether this person had TB infection and prevent the infection from progressing to disease. The right-hand side of the panel looks at this idea of who are the major providers that serve the highest volume of patients who are at high risk. So to look at data sources to identify providers that serve high-risk patients, if we look at, let's see, I wanted to see if okay, so I was going to shift over to, oh, here we go, San Diego. Okay, so up until this point I've been talking about California statewide data. Now I want to give San Diego as an example. San Diego is one of our local health jurisdictions. It has, the second or third highest number of TB cases in California, and it's on the border with Mexico. And this jurisdiction, their TB program actually queries their TB patients on their intake form to say, where did you receive care in the 2 years prior to your having your TB diagnosis? And so San Diego's recently implemented this form, and so I haven't seen any data from them yet in terms of looking at it, but this is the type of form that we could look at, analyze the data and determine, do certain providers show up more often than others? And if so, those might be the ones we would want to start to work with. Okay, what about using administrative data sets? So here I'm talking specifically about those federally qualified healthcare centers because there are some data available on them through the HRSA website. So we have a poster, my summer student Marina Wang Kim and Peter O, who many of you saw at NTCA last year, who spoke at our SCTC meeting last year, has done the majority of this work. Basically what they did is they identified data for federally qualified healthcare center grantees who run more than one clinic, usually. They merged those data with census data to find out where the clinics were located, and they were able to identify characteristics of patient populations because these data are collected by the funding organization. So this is just a diagram of putting different kinds of data sources together and trying to link the facility or the clinic itself to patient population risk. So this slide shows some of the data we get at the grantee level. So in San Diego in 2014, 19% of the estimated population of San Diego was served by 13 federally qualified healthcare center grantees. Those 13 grantees operated 122 clinics. And so you can see we were able to collect data on the total volume of patients per grantee. Not only this, the slide doesn't show it, it's shown in summary in the next, but we're also able to collect the proportion of patients served by each grantee that had diabetes, HIV, homelessness, and a few other risk characteristics that we consider, those that are markers of vulnerable populations who would be at risk of disease. And so this just shows a summary slide of some of the information that we could share with San Diego about risk factors and populations by FQHC grantee. And so here, really what I just want to focus on here is this idea that we also get data on race ethnicity, which is sometimes correlated with birth status. We're not able to get data on nativity, so no birth status is collected in these data sets. But sometimes race ethnicity can be a good marker, particularly in San Diego, which is on the border with Mexico. And so we are able to start to identify different clinics that serve populations having these conditions that are risk factors for progression. And we are also able to map the location of those clinics and look at census data to say, are those clinics located in census geographic areas that have a high proportion of persons who were born in another country? Okay, so as you could see, we keep getting more indirect to try to get at our question, because we still don't have exactly the right data that we'd like to have. But it's, again, an estimate. And so the other thing that Marina did is that she actually mapped the location of these FQHC clinics in San Diego. And so the panel on your left is showing shading of geographic regions by percent foreign-born. So the darker shaded areas are areas where there's a greater proportion of foreign-born, 30 to 60% in the darkest areas. And then the lighter shaded areas have a lower percentage. As you can see, there are many FQHC clinics located in those areas. The panel on the right shows a map of the actual TB cases that were reported. And so the shading there is actually showing the darker green represents a higher number of TB cases reported in those geographic locations. And again, lighter shading is fewer TB cases. These two maps are somewhat overlapping in terms of proportion foreign-born and number of TB cases reported, but not completely. And so we want to continue to explore what are those differences, are they meaningful, and can they help us maybe, again, make priority decisions about the kinds of providers we might want to work with for increased TB prevention activities in San Diego. Finally, is TB prevention optimized? How many minutes do I have? Thank you. So here we were able to work with our large HMO. We did a research study with them in partnership, and Penn and Barry and Katya Salcido were very involved, as well as our registry staff. Basically investigating of the TB cases that were reported in a 2-year cohort, a recent 2-year cohort. How many were within the HMO system up to at least a year prior, were they patients, and they did not receive screening for latent TB infection? And did they have risk factors that should have alerted those providers at the HMO to do some screening? And these HMOs, we've estimated, serve 14% of our TB patient population. And what we found is, I'm not going to give you the details, but basically, yes, indeed, there were missed prevention opportunities there. And so, again, as TB programs are grappling with decisions about which providers should we work with, we can't make assumptions that maybe larger providers who have good policies in general still may have some places where improvement could be useful, and where, if there were improvement, there could be a high impact on our prevention activities, positive impact. Finally, I just put up this slide to go back to this idea of the undocumented and those patients who really are not accessing care. We really don't even know how to look at this group. We do know that, for example, with San Diego's question related to where was your primary care before you came here, we can identify what is the percentage of patients who don't answer that question, and we can make an assumption that perhaps that means they did not access care before they had TB diagnosis. So that might give us a sense of the frequency or the total number of folks who are not accessing care. But in terms of how to access them, folks without a medical home, that's a whole other question. But we can't forget about this population. We need to keep it on our list. So finally, as I said, I just wanted to walk through some exploratory strategies about how do we start to focus our efforts on the highest risk folks for TB, how do we prevent TB, what kind of data can we collect, so we are able to use our health department data. We should probably be doing that routinely. We have it, it's available, and we still need to figure out how best to go into the private sector and figure out what's happening there. So very specific limitations of the FQHC data sets include this idea that the grantee level data is not equivalent to clinic level data, so there's a lot of potential for misclassification there. Population risk intersections are not equivalent to individual patient risk intersections, and so that's another potential issue. We're making mapping assumptions when we start to say a clinic's located in a certain census tract with a high proportion of foreign-born. We don't know if the foreign-born folks in that particular geographic area are going to that FQHC clinic, so that's a major assumption right there. And really I wanted to point out that just looking at the FQHC data is really only a piece of the larger puzzle. The FQHCs in California serve about 11% of our population. So, 11% is smaller than the 14% that our HMO serves. And of course, we have a changing landscape. So when Marina ran the numbers for the FQHCs in 2013 compared to 2014, already there was a huge difference. A lot more clinics were getting granted funding, and they're changing hands too. So what are the next steps? We'd like to further explore these administrative data sets as well as others. We're trying to work with our Medi-Cal, which is our form of Medicaid office, to see what kind of data we can abstract from them about the current testing practices in the state of California for folks with Medi-Cal. We'd like to figure out how to validate some of these approaches. We are working with our modeling partnership. Well, the modeling partnership as a whole is going to help us have much more robust estimates of latent TB infection for our jurisdictions. There's the 4-state model. They're working with California, Florida, Texas, and New York to, get to this point where we really can have better estimates of LTBI. So what's our denominator? Who are we really going to need to work with? And the CDC-funded TB Epidemiologic Studies Consortium is planning to, our next steps there are to assess current health department TB prevention activities, as well as methods to identify private providers with the goal of eventually working interventions with private providers to increase TB prevention activities. So a lot of folks contributed to my presentation, and most of them from my colleagues at the state, and of course San Diego TB program folks, Marisa Moore, Kathy Mosier. Thank you, and if I'm out of time, I'm going to introduce Jay.